waking up every single morning wondering, is today the day my phone rings and I get my life back? Or is today just another day of trying to survive?
Yeah. I mean, it is just this relentless reality. For a patient waiting for an organ transplant, literally every time their phone rings, their heart legitimately skips a beat. They're living in this constant state of suspended animation.
Right. Their entire future is just hinging on a phone call that honestly might never come. Well, welcome to an episode of the Super Nurse Podcast. And we want to establish something really important right out of the gate today.
Yes, definitely. We are not Brooke Wallace.
Exactly. Brooke is the brilliant creator of this episode. She is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and, published author.
We are just here to serve as your guides, really. We're building this conversation directly from Brooke's incredible bedside knowledge, her clinical notes, and her signature teaching style.
Yeah, our whole goal today is to help nursing students and new nurses learn how to think, right? Not just what to memorize for a test.
Exactly. We want to help you take all that textbook knowledge and actually apply it to real, high-stakes patient care at the bedside.
For sure. And before we jump into the clinical details, we want to invite you to subscribe and watch the comic book-based video for this episode on YouTube. You can find the link in the description for our channel, Super Nurse Comics.
It's such an amazing resource, especially for those of you who are, visual learners. It really helps lock in these complex concepts.
Oh, absolutely. So let's just unpack the reality of the transplant wait list, because before we even touch the bedside care of a donor, we really have to look at the person waiting on the other end of this whole process.
Right. And clinical experience shows us there are currently over 100,000 people on the national transplant waiting list in the U.S. alone.
Wow, 100,000.
Yeah. And the average wait time, we aren't talking about a few stressful weeks here. It stretches from months to 3 to 5 years.
3 to 5 years of just waiting for the phone to ring. And I think what newer nurses often find confusing is the sheer mechanics of that list. People assume it operates like a deli counter.
Oh,
right?
yeah, the deli counter myth. You take a number, you wait in line, and when they call your number, you get your organ.
Exactly. But it is absolutely not first come, first served. The patients on that list have to walk what Brooke calls a clinical tightrope, which honestly just sounds like an agonizing way to live.
The tightrope is a very accurate metaphor. I mean, to get an organ, a patient has to be sick enough to reach the top of the medical urgency list. But simultaneously, they have to be healthy enough to actually survive the massive surgical trauma of the transplant itself.
Wait, so if they get too sick while they're waiting?
They get pulled off the list.
Man, that is just an insane balance to strike. If I were to visualize that, it's almost like trying to secure a mortgage while your house is actively burning down.
That's exactly it.
You need the rescue immediately, but the bank won't approve you if the damage is too far gone.
That captures the desperation perfectly. And the allocation logic that dictates who gets rescued first is incredibly complex. It's managed by UNOS, the United Network for Organ Sharing.
Right. They handle the whole matching algorithm.
Exactly. They maintain this massive national database that runs a matching algorithm based on very strict biological and logistical variables. Blood type is paramount, obviously. Yeah. Then you have body size, which is absolutely crucial for hearts and lungs.
Oh, meaning you literally cannot put a 6'2" man's lungs into a 5-foot-tall woman's chest cavity.
No, you really can't.
The physics simply won't work, right? The lungs would be too large to inflate properly, and the rib cage wouldn't even close.
Precisely. You have to match the anatomical volume. The system also looks at tissue compatibility, so they heavily evaluate human leukocyte antigens, or HLA typing.
Which is super important for kidneys, right?
Right. Massively important for kidneys. It prevents hyperacute rejection, which is where the recipient's immune system just violently attacks the new organ right there on the operating table.
Yikes. So they check all that, plus the medical urgency.
Yeah, they use scoring systems like the MELODY score for livers to determine who will statistically die first without the transplant.
And there's also a geographical factor, right? Because these organs have a very strict shelf life outside the human body. They can't just be FedExed across the world.
Very strict. Hearts and lungs are highly sensitive to ischemia, tissue death from lack of oxygen. They are only viable for about 4 to 6 hours once they are recovered from the donor.
Only 4 to 6 hours. That is no time at all.
None. Livers can last a bit longer, maybe 8 to 12 hours, and kidneys can sometimes make it up to 24 or 36 hours on a specialized pump. But time is always, always the enemy.
So thinking about this from the patient's perspective, How does a recipient manage the emotional whiplash of knowing that their ultimate miracle, like the phone call that saves their life, fundamentally requires someone else to have the absolute worst day of their life?
Yeah. It is the profound ethical and emotional tension at the very heart of transplant medicine. And, it brings us directly to the other side of this delicate equation, the donor family.
Right. Because when we talk about organ donors, we generally aren't talking about a peaceful passing at age 95 after a long expected illness. We're usually talking about sudden, devastating, catastrophic trauma.
Exactly. A severe car accident, a ruptured brain aneurysm out of nowhere, or sudden anoxia from a cardiac arrest where the brain goes without oxygen for just a little too long.
So the family is thrust into the intensive care unit completely unprepared.
Right. One minute they were having breakfast with their loved one, and the next they were standing in a sterile ICU room being told there is no brain activity. It is an abrupt, incomprehensible shock.
I can't even imagine trying to process that reality.
Yeah.
Especially in a hospital setting with all the alarms and tubes.
It takes time. A lot of time. But the evidence tells us that donation often acts as what psychologists call emotional and spiritual capital.
Emotional capital. So you're saying they find tangible value in the loss, like it gives the tragedy a purpose.
Yes, exactly. Families frequently express that they find profound peace knowing their loved one's death wasn't entirely in vain. The loss remains horrific, obviously, but the act of donation creates a living legacy.
And the sheer statistical impact of that legacy is staggering. Just looking at the math, one single donor can save up to 8 lives through solid organ donation.
8 entire lives.
We are talking about the heart, both lungs, the liver, both kidneys, the pancreas, and the intestines. And beyond that, they can heal up to 75 others through tissue donation.
Yeah, tissue donation is huge. Bone, tendons, skin grafts for burn victims, corneas.
Corneas. So one single person can restore sight to 2 people and save 8 from imminent death. That's just... wow.
It really is. And what is truly beautiful is how hospital staff honor that immense sacrifice. If you work in an ICU, you will likely witness an honor walk at some point in your career.
Oh, I've heard of these. The concept gives me chills.
It's incredibly moving.
The patient is being rolled from the ICU down to the operating room for the surgical recovery. And the hospital staff, like the nurses, doctors, respiratory therapists, even housekeeping and security, they all line the hallways in total silence.
Yeah. It is a powerful, sacred moment of respect for the donor's final journey. It validates for the grieving family that their loved one is seen as a hero.
That's so beautiful.
And that support doesn't end when the OR doors close either. What we know from practice is that organ procurement organizations provide extensive bereavement aftercare.
Oh, really? I didn't realize they stayed involved.
Oh, absolutely. They offer dedicated support groups, crisis management counseling, and they even facilitate safe, anonymous correspondence between donor families and recipients, usually right around the anniversary of the donation.
That is incredible. But, okay, putting myself in the shoes of a newer nurse for a second. When a family is in the absolute shock of a sudden, unexpected loss, isn't it incredibly overwhelming or even inappropriate to ask them for their loved one's organs right in that moment? Like, how do hospitals even navigate that conversation without causing more trauma?
It is deeply overwhelming, which is exactly why who does the asking and when they do the asking is strictly regulated by law and hospital policy. You do not just wing this conversation.
Oh, you can't just casually bring it up.
Never. This is where we introduce the Organ Procurement Coordinator, commonly referred to as the OPC.
So the OPC is essentially the air traffic controller of this whole process.
That is a brilliant way to look at it. The OPC is a highly specialized professional who bridges the gap between the grieving family in the ICU and the waiting recipient on the UNOS list.
Who usually does this job? Are they doctors?
They are often former ICU nurses, respiratory therapists, or paramedics. These are people who are deeply comfortable with high-stakes critical care physiology and highly complex family dynamics.
Okay, so when do they actually step in? Because they aren't just hovering in the waiting room waiting for people to get sick.
No, definitely not. They operate on very specific clinical triggers. Hospitals have protocols that mandate when the bedside care team must alert the organ procurement organization.
Like what kind of triggers?
Well, for example, if a patient has a severe neurological insult, like a massive brain bleed, and their Glasgow Coma Scale, their GCS, drops to 5 or less, the bedside nurse or doctor is legally required to make that call.
Let's translate that for our nursing students.
Yeah.
The Glasgow Coma Scale measures neurological function. A normal alert person is a 15, right?
Correct.
So a GCS of 5 or less means the patient is deeply, profoundly unconscious. No eye opening to pain, no verbal response whatsoever, and abnormal motor posturing, like decerebrate posturing where the arms extend out rigidly.
Exactly. When a patient hits that trigger, the OPC comes in and quietly evaluates the patient's chart in the background. They check medical history, lab trends, and viability. But, and this is crucial, they do not approach the family yet.
They just stay out of sight.
Yes. They wait until the medical team has officially performed the brain death exams and officially declared brain death. Only after the family has been informed by the doctor that their loved one has passed does the OPC step in to guide them through the donation option.
Okay, so let's say the family says yes, they consent to donation. What happens next? Does the bedside nurse just keep doing what they were doing?
The dynamic shifts dramatically at that point. Once consent is signed, the OPC literally takes over the clinical management of the donor. They become the primary provider writing the orders.
Wait, really? So the OPC essentially shifts the entire medical focus.
Completely.
The team goes from trying to save the patient to trying to save the organs. It's almost like operating a highly specialized intensive care incubator just for that 24 to 72-hour window before surgery.
That is precisely what happens, and it is a massive physiological undertaking. Because, the moment brain death occurs, the body's central command center completely shuts down. And I mean a total systemic collapse.
Because the brain controls everything.
Exactly. The brainstem herniates, and initially you might see what we call a sympathetic storm or a catecholamine surge. The body just dumps massive amounts of adrenaline, causing a huge spike in blood pressure and heart rate. But once that burns out, the central nervous system goes offline completely.
Which means the autonomic functions we just take for granted absolutely vanish.
Yes. The hypothalamus stops regulating temperature, so the patient becomes poikilothermic.
Poikilothermic meaning they just take on the temperature of the room.
Right. They will freeze if you don't aggressively warm them. The blood vessels lose all their sympathetic tone, so they massively dilate, causing the blood pressure to absolutely tank.
And what about the endocrine system? Doesn't the pituitary gland sit right at the base of the brain?
It does, and when it loses blood flow, it stops producing antidiuretic hormone, or ADH. This throws the patient into a condition called diabetes insipidus, or DI.
Oh, I remember learning about DI. That's when the kidneys lose the ability to concentrate urine, right?
Spot.
So the patient just starts dumping massive amounts of dilute urine. Like you could see a liter or more pouring into the Foley catheter every single hour.
And think about what that does hemodynamically. If they are dumping a liter of fluid an hour, their blood volume is plummeting.
Which drops the blood pressure even further.
Exactly. Which means the organs are losing perfusion. So while the bedside nurse is trying to manage this physiological chaos, the OPC is writing the orders for ventilator adjustments, hanging vasopressors to clamp those blood vessels back down, ordering thyroid hormone replacements, and giving medications like vasopressin to stop the DI.
Wow. All while trying to find a home for the organs.
Yes. The OPC is simultaneously drawing endless vials of blood for tissue typing, running the UNOS match list to find recipients across the country, and coordinating the logistics of multiple different surgical teams.
You could have teams flying in from all over.
Oh, yeah. You might have a heart team flying in from Ohio, a lung team from Texas, and a liver team from New York. And the OPC has to perfectly time their arrivals so they all scrub into your hospital's OR at the exact same minute.
It is an unbelievable logistical puzzle, like air traffic control during a hurricane.
That's a great way to put it.
But while the OPC is orchestrating that massive big picture, it's the bedside ICU nurse who is executing the minute-to-minute care. And this brings us to one of the most critical concepts for bedside nurses to understand, the decoupling technique.
Decoupling is paramount. To put it in plain English, the bedside nurses and the doctors who are actively trying to save the patient's life must never be the ones to ask the grieving family for organs.
I feel like we need to repeat that for the students in the back. Never.
Never. Those two conversations, the physician explaining that, your loved one has passed away and the OPC asking, would you like to donate their organs, must be completely decoupled.
Decoupled. Got it.
They must be separated by time and they must be separated by personnel.
Why is that rule so rigid, though? Is it just a professional courtesy?
No, it is about preserving fundamental trust. We must protect the public's trust that the hospital did everything in its power to save their loved one and wasn't just looking at them as a convenient source of organs.
Oh, wow. Yeah.
If the same doctor who says, I'm sorry we couldn't save his brain, immediately follows up with, can we have his kidneys?
Mm-hmm.
It creates a horrific perceived conflict of interest.
That makes total sense.
The family needs a beat to actually process the finality of the death before a separate, specialized person. The OPC approaches them about the next steps.
Right, especially because processing brain death is uniquely traumatic and confusing for a family. I mean, from their perspective, the patient's chest is still rising and falling because of the ventilator. Their skin feels warm to the touch because of the warming blankets. The heart monitor is still beeping.
Right, it doesn't look like our traditional understanding of death.
Exactly. Which is why the bedside nurse's communication has to be so incredibly careful. You use the words mechanical ventilation, not life support, because there is no life left to support.
Such an important distinction.
But the other massive challenge for a newer nurse is shifting their own internal mindset. You are now aggressively treating a legally deceased patient. It feels entirely contradictory to everything you learned in nursing school.
It really does. You are taught your whole career to save the patient. But here, the mindset has to abruptly shift to optimizing the gift. You are providing one-to-one, exhaustive, intensive care to maintain organ viability, to stave off cardiopulmonary arrest, and to prevent ischemia.
So what does the nurse actually do at the bedside during this critical 24 to 72-hour window?
Well, they have very strict clinical targets they must hit to keep those organs healthy. Primarily, they need to keep the systolic blood pressure, the SBP, greater than 100.
Greater than 100. Because if the top number of that blood pressure drops below 100, the perfusion pressure isn't strong enough to push oxygenated blood into the tiny capillary beds of the kidneys and the liver.
Exactly.
Those organs will essentially suffocate and fail before they can ever be recovered.
They will, and they're also constantly fighting to maintain normothermia. Like we discussed, the hypothalamus is gone. So the nurse is constantly adjusting warming blankets or fluid warmers to keep the core temperature normal, because cold organs become dysfunctional.
So they're managing temp, they're managing BP.
They are rigorously managing fluid resuscitation to ensure good, consistent urine output and keeping oxygen saturation, the SO2, greater than 92% to protect the lungs and the heart.
And the interventions to hit those targets are just nonstop. Like you're drawing frequent labs for tissue typing, you are frantically replacing potassium and magnesium as the electrolytes go completely haywire.
That's constantly replacing electrolytes.
Right. And you are assisting with bedside diagnostics, maybe traveling with the patient down to a CT scan, or helping a pulmonologist perform a bedside bronchoscopy to evaluate the health of the lungs.
Or even sending the donor to the cardiac cath lab to ensure the coronary arteries are completely clear for the heart recipient. It is incredibly active, exhaustive nursing.
It sounds like it.
And, before we move on, we should also clarify that not all donors are brain-dead donors. What the research shows is a significant increase in what we call DCD donation after circulatory death.
This is a really important distinction. Let's break that down. A DCD is for patients who have suffered a devastating non-survivable injury, but they do not meet the strict neurological criteria for brain death.
Correct.
So they still have some minimal brainstem reflex, perhaps triggering a few spontaneous breaths over the ventilator. In these cases, the family has made the difficult decision to withdraw life support and pursue comfort care.
Yes. And in a DCD scenario, the bedside nurse's role changes dramatically. Because the patient is still legally alive, the OPC cannot manage them.
Oh, that makes sense.
The bedside nurse actually accompanies the living patient down to the operating room. The nurse administers the comfort care medications, the morphine for pain, the sedatives for anxiety, and the nurse, or respiratory therapist, performs the terminal extubation, removing the breathing tube right there in the OR.
And where is the surgical recovery team during this? Like, are they just hovering over the bed waiting?
No, absolutely not. The surgical team is waiting in a separate room, completely hands-off. The bedside nurse focuses entirely on providing a peaceful, pain-free passing for the patient, with the family often present at the bedside.
So the surgeons don't come in until?
The surgical team only steps into the room after the patient naturally passes away, and the attending physician officially declares circulatory death based on the cessation of the heartbeat. The nurse hands over care only after the passing. It requires immense grace, clinical vigilance, and, frankly, emotional strength.
I have to pause here, though, because I can hear nursing students listening to this and feeling their heart rate creeping up.
It is a lot to take in.
Right. If I am a new grad ICU nurse, I am already overwhelmed just trying to keep my living, breathing patient stable. Now you are telling me I have to coordinate with an external OPC, manage the psychology of a deeply grieving family, rapidly replace electrolytes dumping from diabetes insipidus, and hit absolutely perfect hemodynamic targets on a brain-dead patient. Like, how do I prioritize this without just completely freezing up?
It is a completely valid fear. It is overwhelming at first, and it's okay to feel that weight. But here is the secret to getting through it. You do not have to do it alone.
Okay, that's reassuring.
The OPC is your partner at the bedside. They are taking the cognitive load of deciding what to order off your plate. Your job as the bedside nurse is to prioritize exactly what you already know how to do.
So relying on your core nursing foundations.
Yes. If the blood pressure drops on the monitor, you titrate the vasopressor up, just like you would for any other patient. If the oxygen drops, you assess lung sounds and suction the airway.
Just normal ICU nursing.
Exactly. You treat the hemodynamics of this donor with the exact same urgency you would a living patient. Because, and this is the absolute key to not freezing up, you are keeping future recipients alive.
Wow.
You are literally maintaining the temporary life support for a liver, for lungs, and for a heart that is going to beat inside someone else's chest tomorrow.
That fundamentally changes the perspective. You aren't treating a deceased patient. You are essentially treating 5 to 8 living patients who just aren't in the room yet.
Exactly.
You are their critical care nurse before they even get to the OR.
When you look at it that way, it shifts the burden from this is terrifying and overwhelming to this is an incredible, profound honor. You are the guardian of their second chance.
Okay, let's kind of bring all these concepts together. We have covered the incredible, complex journey of an organ today. From the terrifying tightrope of the recipient waitlist, where patients balance on the edge of survival, hoping they don't get too sick to qualify for surgery,
to the donor family, finding true emotional capital and a lasting legacy in the midst of an unimaginable, sudden tragedy.
through the masterful coordination of the OPC, acting as the air traffic controller for multiple surgical teams and complex matching algorithms.
And finally, to the vigilant, minute-to-minute hemodynamic support of the bedside nurse, battling massive physiological shifts like diabetes insipidus and cardiovascular collapse.
So, for the nursing students and new grads listening, here is your practical bedside takeaway. Remember the critical rule of decoupling. Never initiate the donation conversation yourself.
Leave that to the OPC.
Right, leave that to the OPC so your medical team can preserve the family's trust. And when you are managing that donor, treat the optimization of their vitals, keeping that systolic blood pressure over 100, that oxygen saturation over 92%, with the exact same urgency as you would your most critical living patient, because you're keeping future recipients alive.
We really want you to walk away from this discussion feeling a tangible shift in your clinical confidence. We want you to be able to look at this intimidating process and say to yourself, okay, this matters, but it actually makes sense now and I can use it at the bedside.
Okay, this matters, but it actually makes sense now, and I can use it at the bedside. That is exactly what we want you to feel as you step onto your unit. Next time you walk into the ICU, consider the culture of your hospital. Pay attention to how your team handles these moments. How well does your unit honor that invisible, sacred line between the end of one life and the beginning of several others?
It's a profound thought to carry with you into your next shift.
It really is. Well, thank you so much for joining us for this episode of the Super Nurse Podcast. Don't forget to watch the comic book video for this episode on YouTube. The link is in the description for our channel, Super Nurse Comics. Like, subscribe, and leave a comment. We read all of them and love hearing from you. And finally, be sure to visit supernurse.ai for great resources helping you become the super nurse you were born to be.
Keep looking past the monitors. Trust your training and keep advocating for your patients, both the ones in the bed in front of you and the ones waiting at home for the phone to ring.